Sure. So first, to the first issue raised, we don't know whether moving to an experience-based methodology would be higher cost or lower cost. It's certainly possible that it's higher cost. My point was that if, in fact, the thought is that we're currently underpaying, then an experience-based methodology should resolve that issue for the PACE organizations. We aren't convinced that we are underpaying, which is why we don't support moving to just paying at a higher level of the UPL. Certainly, the change in the methodology was really based on the fact that although they are all nursing facility level individuals, they are not actually residing in a nursing facility, and so using a combination.
Which was the point of the program.
Exactly. And so when we look at similar programs, we've looked actually at our rate setting for our CalMedi Connect program. What we're seeing is that when you actually compare the PACE rates to the rates that we'll be paying under that program, there's actually a fairly large rate differential. The PACE rates are going to be nearly resulting in 8.5% higher. And so
MediConnect does not deal with the same type of population.
Yeah, it deals with a similar population. So we were focused just on the institutional and the home and community-based population under CalMedi Connect, which is a similar nursing facility eligible criteria individuals. There are individuals who are eligible for CalMedi Connect are eligible for PACE. It's not the entire same population, so we focused on those who would be potentially eligible for PACE to look at this rate differential. So again, our concern is, why stick with a methodology that is a fee-for-service-based methodology that the PACE organizations also have concerns about as we move more people into managed care? Again, that's the additional language in their trailer bill is, well, we need to use other data to try to smooth out the issues. And so if we actually move to an experience-based methodology, we wouldn't have these challenges that exist now.
Do you plan, you're doing an analysis now for the experience-based recommendation?
Yes, so we have a work.
So what's your deadline?
Well, we've been trying to work for the past couple of years on this with the PACE organizations, and I know that there is interest in moving forward, but we've been continually stuck sort of focused on what the next year's rates are using the UPL methodology, and so we haven't been able to move forward with them in as much speed as we would have liked. And we knew that given the past rejection of the proposal, until we had the support of the PACE organizations, we didn't put forward any proposed language because it's been rejected in the past because we didn't have their support. So we're trying to continue to work with the PACE organizations. As I said, we value the program very much. We think it's very important, but we do think that moving to a different methodology would be the right way to go.
Do you think the new methodology, and I don't really want to, I guess we shouldn't get into it, but would produce probably more visits in order to create more money?
I don't think so. I mean, that it's a actuarially based methodology that we use for other Medi-Cal managed care plans. It is a very common way to do rate setting.
Okay. Are there any? Yes.
Last comment is, I think one of the difficulties we have is that while there are some aspects of some of the other programs that are comparable or similar to PACE, I think that PACE was established because there is no other program that is comparable. So partly because the way PACE was structured is that it provides, and I know you know this, but I'm just repeating for sort of our collective benefit, the primary and specialty medical care, the in-home services, the home care, the prescription drugs, the laboratory and diagnostic services, the physical and occupational therapies, meals, transportation, and so it's more comprehensive than any of the other programs. So that is why it was hard for me to imagine that we could, in a use-based compare one to another, because there's not another program that's comparable. Nothing that provides that level of comprehensive services.
No, and I think that's true. Obviously, being a staff-based model, very different from our other Medi-Cal managed care plans. But I think that's what would make going to experience-based methodology make more sense instead of looking to a fee-for-service equivalence where, as you said, it's not the same types of services necessarily that are being provided in a fee-for-service world that are being provided through PACE. So we think that really does support the idea of can we move forward? Obviously 2014 it's too late for that, but how do we move forward in a way that we can move to experience-based?
Well, if we have programs now that, due to the cuts that we've been making to it since 2008, that could be closing doors, it is hard to imagine that any formula that you would use that would retain, again, its purpose is to keep these elderly that it serves out of nursing homes. I don't see how we could save money since we're now at risk of having to close facilities or close programs. They're not facilities, programs.
And again, like I said, we don't know what the movement would result in. It would be based on data that we do not yet have collected and worked through with the plans.
I guess the question also would be whether or not the current program, and it's regardless of whether what method you're using for to determine the amount, whether the program in its current state, once again, as we talked about, has benefits financially because it saves us money. We can definitely figure out how much it would cost for us for the people to be in nursing homes, and see that cost in comparison to them being involved in a PACE program. And I'm sure it's much greater because those are high cost places. Number one. Number two, and like I said, we're in a finance meeting, so sometimes we don't like to talk about quality of life, but quality of life in terms of what life is like when you're in a nursing home versus those who have the opportunity to remain in their houses and get support and services and rehabilitation at the same time that I've seen them get, and what happens in terms of quality of life for those individuals. So, but I do know we know there's some savings from being in a program like PACE in comparison to being in a nursing home. I assume we do know those two costs, right? What's the difference?
I don't know off the top.
But I know nursing homes are very expensive. And so they're much more expensive than being in your own home and having the cost of having care that comes in, or transportation, or all those things, much more expensive. So we do know there's a savings just in that, as well as possibly the quality of life. You know, the persons you talk to in PACE who are there every day talk about the quality of life, the change, the impact on their lives, and how it's a much better situation than being in a nursing home. It would be interesting to see, too, and I guess that's for future researchers who are interested in terms of not only quality of life, but longevity in terms of whether people who go in nursing home live shorter lives than those who remain at home. And I think there are some discussions about that in terms of enhancement of a person's options, choices, their outlook on life, and their willingness to live a little bit longer, even if they're elderly. So it'd be interesting to see. Do we have any? Yes, staff.
One other factor hasn't been mentioned, and frankly, we as a state are very fortunate we got through this recession without being sued over whether compliance with Olmstead and whether we're adequately giving people under the Americans with Disabilities Act, giving individuals with disabilities the services they need to live in the least restrictive environment. One just has to hope in this case that while we're trying to figure out what the right methodology is, we don't lose some programs and thereby fall even further back than we did during this dreadful budget mess we've been in offering the services that Olmstead requires us to do, and frankly, respectable, humane concern for people requires that we do. But I do think that needs to continue to be a consideration. I think that, our respectable organizations that represent disabled people in the legal process have been very restrained, but as money improves and the state gets back in a stronger position, I think, the longer we delay the reversal of the starvation that we have and elimination that's gone on with numerous programs, the better position will be in court if somebody tries to sue us, and the risk will be reduced. So thank you.
Okay. Do we have any comments? You'll each get a minute in favor of the proposal.
Thank you. Peter Hansel with CalPACE, the State Association. This is our proposal that you're hearing today, and we appreciate your taking time to hear it. There's no doubt in our mind that PACE saves money. We do estimate the total savings at the moment are on the order of about $20 million to the state and federal government. That's because the rates are deliberately set below the cost that it would cost the program if the participants were cared for in fee-for-service Medi-Cal. So we're here because the current methodology has produced about 6 years of flat and declining rates for PACE programs. It's illustrated in your analysis. We would totally agree with the department. The methodology is flawed. We have been discussing with the department different methodologies, and we're certainly open to an experience-based methodology. I think it's important to point out that PACE programs have not rejected an experience-based methodology. We have had a problem with the version the department has put forward because it has not recognized all the costs that PACE provides. So a health plan-based actuarial methodology is great if you're looking at services that are traditional healthcare benefits, but PACE provides a lot of non-traditional benefits that don't show up in the cost sheets, and that's been the problem that's led to the delay, and I want to make that point for the record. It also will take time to develop a new methodology. I think that's an important point to make. It's not something that will happen overnight. The programs are suffering in the near term and need an adjustment to the current methodology, and I think our representatives that we have today will be able to describe why that is. Thank you.
Thank you.
Madam Chair and members of the committee, thank you so much for hearing us today. I'm Carol Hubbard. I am the Executive Director of St. Paul's PACE down in San Diego. We have two centers, one in Chula Vista and one downtown, and we serve 380 frail participants who, as you all are aware of, they're nursing home eligible seniors living in their home. What I wanted to tell you is that St. Paul, since we've opened our doors in 2008, we haven't seen an increase in our rates for the duals population, which is about 85% of our population. We actually have seen rates reduced by 13% since then, primarily due to changes in the rate methodology. And we've absorbed also the impact of the across-the-board changes of the 10% provider rate reduction as well. So we really question whether or not, we can continue as a PACE organization with the being able to financially be viable. In addition, we were also considering expanding to the Imperial County, where there are very frail seniors that are in a rural county that are unable to be served because of the methodology. We're not able to serve them. So it has definitely impacted in San Diego area.
Thank you.
Hello, I'm Joyce Hayes, Executive Director of the Humboldt Senior Resource Center. At this point in time, there's no PACE in Humboldt County. Since 2009, we've been working with health professionals and with the Humboldt Senior Resource Center in bringing PACE to Humboldt County. It's our goal to open Redwood Coast PACE in the fall, and we will be the first rural county in California to have a PACE program. As an organization, we've invested several $1 million in the development, and we look forward to 2 to 3 years of financially not breaking even. So I am greatly troubled by the downward trend that we see in PACE rates. 3 weeks ago, we received our rate for opening in the fall, and we received a rate that's 10% below all the very lowest existing PACE program in the state. This concerns me greatly in terms of our stability and long-term feasibility of this program. And we feel that there needs to be stable and predictable rates for all PACE programs if we really bring this quality program to the state. Thank you.
Thank you.
Madam Chairs, there are two of you here, and members, Gary Passmore with the Congress of California Seniors. Thank you for some of the questions and some of your in-depth drilling down on this issue. This request for PACE is one of our very highest budget priorities this year. And let me try to answer a couple of questions by creating some context. The Coordinated Care Initiative, with all due respect, is not PACE, and it is never going to be. The CCI will enroll 450,000 people in 8 counties. PACE has 5,000 people in most of those counties today. PACE deals with the greatest acuity, highest need people, and in truth, provides service to some people who have needs that are greater than those in nursing homes, because some people are in nursing homes in California because they don't have access to a PACE. So that isn't really an appropriate answer. We would argue that you need to increase the funding for PACE. They are at great financial risk today, while the state spent several more years working out some new formula that makes sense for this really, really high-need population. Thanks.
Madam Chair, members of the committee, Luis Lopez, Director of Government Affairs for Ultimate Health Services. We are a federally qualified health center operating in Los Angeles and Orange counties. We operate 6 PACE facilities, including 2 that are slated for opening in South Los Angeles in the Watts community and in the city of Covina, which, as you can understand, we are very nervous about as we look at the capital that's required to invest and get these programs started, and given where we are with the rates. As Mr. Passmore indicated, this is a high acuity population. On average, the average age is 78. 18 conditions, medical conditions, 3 to 5 impairments with activities of daily living. So these are very, very frail seniors. The proposal before you would also require DHCS to make rate adjustments in counties where the underlying data used to set rates is flawed, and that to deal with the enormous disparities in rates from county to county. We do know that this is a cost-saving program to the state. In 2013, $20 million was saved if these services would have been provided by outside of PACE. So we know that it's cost savings. We urge you to adopt the trailer bill language. Thank you.
Hello, I'm Dr. Christine Rosance, and I'm currently Chief Medical Officer of Center for Elders Independence in Oakland. However, prior to that, I was the Medical Director at Sutter Senior Care here in Sacramento, so I have a total of 16 years with PACE. And having said that, it is a privilege and pleasure to practice as a geriatrician, and I'm also boarded in hospice and palliative care with this full team. Our numbers indicate that we are doing some very good work. Our comparable population, we have fewer emergency visits, fewer hospitalizations. We at Center for Elders Independence are serving 600 people in 2 counties. We are hoping to expand into the Hayward area and San Pablo. There is great need there, but our ability to optimize our function and our expansion is seriously compromised with the budget cuts that we have had over the years. So I do urge you to adopt the language in the trailer bill. Thank you.
Madam Chairwoman and committee members, thank you for having this opportunity to present. I'm Tori Starr. I'm with the Sutter Health System, representing Sutter Senior Care. Sutter Senior Care was the second PACE program in the state. We've been around for over 20 years. We progressively have increased our enrollment and been able to serve the Sacramento area. We have the ability to go into the Placer County area too. We know that there's a need that exists in those counties and that we could actually serve more folks. At this point in time, we're actually at the place of not being able to do any further expansion until we are able to find some kind of stability in the rate structure. So we are asking you to go, please adopt your support for the trailer bill. Thank you.
Good afternoon, Madam Chair, members of the committee. I'm Ed Thompson. I'm the numbers guy in the group. I'm the Chief Financial Officer for St. Paul's PACE in San Diego. And Carol did a pretty good job of covering the numbers. I was impressed. But what she didn't mention is that we've started 2 PACE centers in San Diego. It cost us $15 million to build those. $15 million to build those centers. A huge outlay on the front end for this thing. We opened the first center in 2008. For 3 years, through 2011, we saw no rate increases in our PACE capitation rates in the state of California. In 2012, the state of California redefined the formula that they use to calculate our rates, and that redefinition, along with AB 97, cost us, again, as Carol said, about 13% reduction in our dual eligible rate for 2012 and 2013. And the other factor is that during that time, from 2008 to 2013, I estimate very conservatively that our costs of providing health care to those individuals went up by 11%. So the combination of those two, I think, puts the PACE program in California at fiscal risk. And you have to ask yourself, can they survive with that kind of a squeeze? Thank you very much.
Thank you.
Nicole Wortelman on behalf of Innovage. It's a PACE program servicing Riverside and San Bernardino counties. It's brand new and is already worried about its long-term sustainability with the current rates. They are strongly supportive of the proposed trailer bill language.
Thank you. Okay. Any opposition? Okay. Any other comments from the committee? Just want to thank you. Want to thank those of you who came from PACE to share this information. This item also will be held open as we continue our discussion concerning the budget. But I just want to say I really appreciate those of you who came from all the places, particularly from my home place, San Diego. Thanks for coming and sharing the information. Some people don't know in my other life, when I was a graduate student, I was a social worker for the Episcopal City Mission Society, and I work with the elderly and with board and care facilities and residential facilities. So that was some of my training as an undergraduate. I backed into this position and had an opportunity to visit many facilities that deal with care and dealt a lot with the issues at the beginning of the whole discussion of geriatric care in the early 70s. And so it is interesting as I look at PACE as a model program that does so much for the elderly, and having seen how they operate, what they do, the care and the support of those agencies that run PACE, it's really quite amazing. The reality is, what we do for our young and what we do for our elderly really determines the quality and the nature of who we are as a nation. And so when I see the very severely, the fragile individuals who hold my hand and say, PACE saved my life, is what a gentleman told me the other day, because he couldn't walk, he couldn't get out of his wheelchair, and here he was in a simulated bike, strengthening his hands and his body, and his fear that because he was 2 or 3 generations of Parkinson's, and so he'd taken care of his mother and grandparents, and here he had Parkinson's and not able to function, and they have done so much for him and just improved his outlook on life. It was really quite amazing to sit there, and I've seen that before, work with the elderly who've been isolated and who've been at home alone, afraid, without care, without support. And so when you have an agency that fills in where we think families ought to be, or it's just healthcare ought to be, it really is amazing. So I know that it's a whole lot different than when I used to go into nursing homes, and I still go into nursing homes sometimes to visit individuals. A totally different level of care and mentality and support. So it is a wonderful program that's struggling along, and it would be a tragedy, once again, short-sighted on our part to talk about the investment now without realizing how much we pay in comparison to what PACE offers. So that's why I always ask the question, if all these people went into nursing homes, and some of them would have to, because they fall and they do those kinds of things, what would the cost be for the PACE? And that really is a question we have to consistently ask ourselves as we look at the programs and whether or not we're really saving money by the things that we do. So I really want to thank this item will be held over. Thank you so very much for coming. Thank you.
Thank you, Ms.
We have one last proposal. I think, is it from LAO that's supposed to put, no, okay, the Department of Public Health is going to present. We have one more for LAO? Okay, yes, I'm sorry, for the Medi-Cal renewal proposal.
I know.
We're just working LAO overtime, huh?
Thank you, Madam Chair. Again, this is a proposal from advocates and not from the administration.
Yes.
The California Endowment has offered to provide funding to the state of at least $6 million to be matched with federal funds and used to pay individuals to assist Medi-Cal beneficiaries with required renewals. This proposal would seek to build upon and utilize Cover California's network of certified enrollment counselors to assist Medi-Cal beneficiaries with renewals. Consumer advocates propose trailer bill language to enable the state to accept these endowment funds, seek federal matching funds, and implement the proposed services.
Thank you. Any comments from?
Yes, thank you. So we don't have a position at this point in time. We are still looking at this. There are some factors that we thought would be important to raise for the legislature to consider. First and foremost is how this would actually interact with what counties do and the renewal work that the county eligibility workers do, as well as the new pre-populated form and ex parte processes that will be in place next year. We really want to make sure there's no duplication of efforts that county eligibility workers are taking under. Also would still need to have some continued coordination with Covered California, as with previous outreach and enrollment payments. We're also aware of recent decisions made by Covered California to relook at their processes of application assistance and making individual payments and possibly moving to grant programs. So we're working with them on this approach and assessing the implications for the Medi-Cal application assistance processes. And obviously we think that would impact how any renewal assistance processes might be best structured. And obviously any decisions would also need to be informed by discussions with the California Endowment, since they are the ones putting up the funding for both those efforts.
Okay. Any comments from Finance? Okay. Any comments from the committee? Okay. Any support statements? 1 minute each.
Beth Capel of Health Access California. We are one of the consumer advocacy organizations that has suggested that it would be wise to accept this money and draw down federal match for it, which is the reason why it is a budget request. The endowment was kind enough to provide very substantial resources last year, which has paid off handsomely in Medi-Cal enrollment. We do not see it as replacing the work of county eligibility workers, but rather complementing it. The experience of many outreach efforts was that in the communities in which outreach was done, a third were Covered California eligible, a third were Medi-Cal eligible, and a third were undocumented, which goes to a proposal you heard earlier in that area. So we think it's important as people face renewals for the first time with all of the new rules. Remember, we have a completely new set of rules for people on Medi-Cal, that they can go back to the people that helped them sign up the first time when they want to renew. Thank you.
Madam Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty. Appreciate you agendizing this item and looking at this seriously. We too appreciate the generosity of TCE in coming forward. We appreciate the comments from the department. A couple of notes there. As my colleague Ms. Capel said, this is in no way intended to duplicate the efforts of eligibility workers. Their efforts can't be duplicated, but they are frankly overwhelmed right now with, you've heard of the hundreds of thousands of backlogged cases, and it's different to have a trusted community-based organization helping them through the process. Frankly, it will help the eligibility workers if the forms are cleared. Also, Ms. Cantwell referred to the pre-populated forms. Those won't start until 2015. And we do have significant concerns about the complexity of the forms this year in 2014. So we know that people go back to the place where they got help in enrolling in the first place, and we want to make sure folks can get through that renewal process. Thank you for your consideration.
Thank you.
Madam Chair, members, Autumn Ogden with California Coverage and Health Initiatives, and we are very grateful for this being agendized and to the California Endowment for providing these funds. We represent the local children's and community health initiatives that have been doing outreach and assistance into local programs and Medi-Cal for over 10 years, and we can tell you that through experience, people do come back to the folks who have enrolled them and they seek help. And also, as we move to getting more and more Californians to be enrolled, we are going to need to focus on retention and utilization as we go forward. So we do appreciate this item and we strongly support moving forward with this. Thank you.
Thank you.
Thank you, Madam Chair. Frank Mecca with the County Welfare Directors Association, and we're supportive of the proposal. We're very comfortable with the fact that no one sponsoring it or supporting it has any intention of duplicating our work. There's plenty of work to go around. I don't think we could give it away at this moment if we wanted to. We just want to make sure that since Medi-Cal renewals it's a different set of competencies. It's very different than the initial application, and it's going to be actually different than renewals that have occurred in the past. And we want to make sure that the department, as the Medicaid agency, is sort of in the leading role of developing curriculum and working with Covered California and working with us. And I'm comfortable that everyone in the room is interested in the same end, so we're in support.
Thank you. Okay. Any other comments? Any opposition? Okay. Is there a motion for recommending approval of the placeholder trailer bill language requiring DHCS to accept monetary contributions from a private foundation for the purpose of providing Medi-Cal in-person annual renewal enrollment assistance payments and to immediately seek an annual amount of federal matching funds? It's been moved in second. Roll call.
Weber.
Aye.
Chesbrough. Aye. Dickinson.
Aye.
Grove. Mansour.
Okay. Thank you. Thank you very much. That now moves us to the Department of Public Health. And there are 3 items on that in the Department of Public Health. First one dealing with California Reducing Disparity Project.
Good afternoon. My name is Jamal Miller. I'm the Deputy Director for the Office of Health Equity of the California Department of Public Health. I'm here on behalf of the California Reducing Disparities Project that we are responsible for with respect to addressing mental health disparities across California, across 5 particular cohorts of people: African American, Latino, Native American, Asian Pacific Islander, and LGBTQ. This is the first of its kind with respect to allocated funding from the Mental Health Services Act Fund of $60 million to address persistent disparities, particularly in these populations. We're looking to evaluate community-defined mental health practices, and the hope and expectation is that we invest a significant amount of this funding into rigorous evaluation to demonstrate its effectiveness. And to build upon that foundation. And a critical part of our ability to do this work over the next 4 to 5 years is to request and to have access to a statutory exemption for the public contract code for the California Reducing Disparities Project. And your support will be greatly appreciated for that.
Okay. Any comments from LAO or Finance? Okay. Any comments from the committee?
Do it.
Do it, okay? Just do it, okay?
Do it.
Any support statements?
Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. Thank you so much, Madam Chair and members, for considering this. We are one of the proud partners of the California Reducing Disparities Project, and this is being watched nationally for its importance in identifying what will reduce disparities in mental health. And so I hope you take the recommendation of staff to move this language. And I also do want to let you know that we really appreciate working with Deputy Director Jamal Miller. He leads the Office of Health Equity, and it is so great to have a partner with government. Thank you.
Thank you.
Thank you, Madam Chair and members. Alice Kessler. I'm here on behalf of Equality California, which was one of the Reducing Disparities partners working in the LGBTQ issues, and we wanted to also support the recommendation that's before the committee. Thank you.
Thank you.
And Mr. Chair,
yes,
I'm sure I suggest you bask in that glow, because that doesn't happen very often in these hearings.
I'm new to
better make a video. Any opposition?
He's going to like the public sector.
Okay. Can I get a motion? Get a motion to approve the placeholder trailer bill to exempt the California Reducing Disparity Project from the Public Contract Code? Okay. Moved in second. Roll call.
Weber.
Aye.
Dickinson.
Aye.
Chesbro. Grove. Mansour.
Thank you. Thank you very much. That brings us to our next item, which is the State Dental Health Director.
Madam Chair, members, Drew Johnson from the Department of Public Health. The finance letter before you proposes to establish 2 positions, including a state dental director and $474,000 in appropriation authority, split funded between general fund and some federal Department of Health Care Services reimbursements. Tooth decay is the most common chronic condition of kids. Low income and underserved children are even more disproportionately impacted by tooth decay. The department, as late as 2008, had a budget of about $3.5 million to establish our oral health program. It has slowly been whittled away with general fund reductions and HRSA-related grants that are non-renewable. Come this fall, when our last HRSA grant expires, we'll have a statewide oral health program of a little over $200,000 to support a community fluoridation program. So this provides us just a modest infrastructure with state health director and a epidemiologist to conduct a burden disease report, a state dental health plan, to do epidemiologic work with Department of Health Care Services on best practices, et cetera.
Thank you. Anything from Finance, LAO? Okay. Anyone from any committee members' comments? Okay. Any support? Yes. Comments for support?
Good afternoon, Madam Chair, members. Jason Bryant, California Dental Association. Establishing a statewide dental director is so critically important for the state of California, because for the first time in many, many years, the state will have an advocate and a leader in state government to to put together a state oral health plan. We're very pleased to support it. The dental director will also be able to pull down federal dollars currently that are not being pulled down by the state of California and go to other states. So it's a great position. We're happy to support it, and I want to thank the governor's office for their leadership in this area, as well as Madam Chair and members in this committee. Thank you.
Thank you.
Thank you, Madam Chair. Members, Aaron Clark, and representing the Children's Partnership in support of the staff recommendations for the State Director. So thank you.
Thank you.
Autumn Ogden with California Coverage and Health Initiatives, also here to support this measure. Thank you.
Thank you. Okay. We have a proposal here to approve the spring letter requesting $474,000, $250,000 from general fund, $224,000 from federal funds for approval of a state dental director, a 1.0 epidemiologist position, and consulting services to establish a statewide dental health plan. It is an embarrassment that California doesn't really have a dental director or a plan to deal with the issues of dental health in California. It's kind of it's one of the many embarrassments, I guess, that exist in a large state that's so prosperous and yet has such a lack of a focus. The fact that you say we have $200,000 is criminal for a state this size to have that budget for the whole state to deal with the issues that are there. Having been raised poor without health care and surely without dental care, I still bear the scars of no dental assistance as a child. And that is a tragedy, because sometimes when you're poor, the last thing you think about is dental health until you're in pain, because you have so many other issues in your life that are very important, quote unquote, and somehow or another your dental care seems to be the last thing you ever think about as a parent, not out of neglect, but just out of necessity of what you have to deal with every day to survive. So, we've got to be a lot more progressive in our care for children, not to make sure that we do the best that we can, and obviously good preventive dental health is important, as well as dental health for our seniors, who were obviously children at the time, and we didn't think much of our teeth and didn't think that they were really a part of our health. And so it's a first step in the right direction, and I want to recommend to my committee here that we approve the spring letter for this support. Can I get a motion?
So moved. Second.
Roll call.
Weber.
Aye.
Chesbro.
Aye.
Dickinson.
Aye.
Grove. Mansour.
Okay, thank you very much. We have one last spring letter. Okay. Issue number 3, licensing and certification investigation. Thank you.
Madam Chair and members, Jean Icino, the Interim Deputy Director of the Center for Healthcare Quality at the California Department of Public Health, here to present to you our spring finance letter. We are requesting position authority for 18 two-year limited term positions and a little over $1.9 million from our licensing and certification special fund to support timely investigation of allegations and complaints filed against certified nurse assistants, home health aides, and certified hemodialysis technicians. Our goal with this finance letter is to improve the timely completion of our investigation timeframes and to eliminate a backlog of cases that we have built up over time so that we can provide better protection to California's vulnerable elderly and dependent adults and children in long-term care facilities and other health facilities where these individuals that we do certify are providing care.
Okay. Any comments from committee? Do we anticipate having any problems finding folks in any of these temporary positions? Or
we do not. Limited term can add a complexity, but the associate governmental program analyst, which is the classification for the bulk of the programs, is a very common classification throughout state service, and we don't anticipate great difficulty in filling them.
Okay. Any support, comments? Any opposition? Can I get a motion to approve this item for a recommendation, approval of the spring letter requesting $1.9 million and 18 two-year limited term positions for investigation, allegations, and complaints against certified nurse assistants, home health aides, and certified hemodialysis technicians?
That is my motion.
It's moved in second. Okay, can I roll call?
Weber.
Aye.
Chesbro. Dickinson. Grove. Mansour.
I want to thank you all for coming. I think that's our entire agenda today, so our meeting is adjourned. Thank you.